Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering part 1 of depression. If you haven't done so already, guys, please make sure that you like this video. You know you're going to like the video. Like this video, press the red notification button, subscribe to this channel. And don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. All right, so we're covering part 1 of depression. Something I want you to keep in mind as you're studying and you're learning and you're reading about depression. At the end of the day, depression is anger, bitterness, resentment, hostility turned towards self. Okay, the person doesn't see any value in themselves. Depression. So one of the ways that you know that patient's starting to get better is if they start to get offended by certain things, because if they're getting offended, that means they have some type of value that they were able to get offended. Okay, I just want you to keep that in the back of your minds. And the reason I'm telling you this at the very beginning, those are the type of questions that I see you as students struggle with and you get wrong the most. And we'll get into that deeper as we get probably part 2, part 3 of depression, but I just want you to keep that in mind. So let's take a look. Major depressive disorder, the clinical picture, what's this patient going to look like? Major depressive disorder is one of the most common psychiatric disorders. Major depressive disorder or major depression is characterized by a persistently, not intermittently, persistently, that means it's not stopping, a persistently depressed mood lasting for at least 2 weeks. Sadness, okay? Look at the DSM-V criteria for a patient being diagnosed with depression. I'm not going over all of this. Oh, let me make this bigger for you. But I will touch upon A. 5 or more of the following symptoms have to be present during that same week period that the patient has that persistent depressed mood, okay? At least one of the symptoms is either depressed mood or loss of interest of pleasure. So things that used to make them happy, such as going to the movies or certain hobbies that they used to find joy out of, they no longer do. Let's take a look at this box 14.1. The primary risk factors for depression. Female gender. That makes sense. And guys, I'm speaking generally here, okay? But generally speaking, in many homes, the man goes out, works, comes home, goes play, bowling or whatever he does to get the stress out, right? But the woman goes to work, comes home, washes the dishes, clean the house, does laundry, take care of the kids, do homework with the kids. Lots of expectations are on the woman to not only provide, but also be a good mother, also be a good caretaker. If it's an older woman in her 30s, 40s, 50s, her parents are getting older, her husband's parents are getting older, who do you think that weight is on to take care of them as well? And guys, I'm only speaking generally, but it makes sense that we'll see this more in women than men. I'm just saying. Stressful life events, such as the death of a loved one. And I put a star next to here because many test questions of when it comes to risk factors, this is what they're looking for. So make sure you know it. First degree family members with major depressive disorder. Remember, guys, when it comes to psych, I'm not going to say all because there are always exceptions, but for the most part, genetics plays a very, very big factor. Okay. And other disorders such as substance abuse, anxiety, personality disorders, etc. So make sure you guys take a look at this box and you know these risk factors for depression, major depression. Psychological factors, cognitive theory. Remember, cognition is how a person thinks, how they process thoughts, right? Make sure this isn't distracting to you. Okay, so in cognitive theory, the underlying assumption is that a person's thoughts will result in emotions. So if the person keeps thinking, I'm not gonna succeed, I'm gonna be a failure, that will result in those emotions. If a person looks at life in a positive way, the person will experience positive emotions, but negative interpretation of life events can result in sorrow, anger, and hopelessness. So remember, cognition is how a person processes thoughts, how they think. So this cognitive theory says that the way a person persistently thinks will have a very big effect on their emotions and how they feel. Beck, this is a theorist, Beck found that people with depression process information in negative ways and tend to ignore positive aspect of their lives. So even if something good happens, they'll only focus on the bad. Or if there's no bad to focus on, they'll be worried that something bad is going to happen because nothing good ever happens in my life for long. So since something good just happened, I'm just waiting for the ball to drop, okay? He believed that automatic, negative, repetitive, unintended, and not readily controllable thoughts perpetuate the depression. So it makes it even worse. 3 assumptions constitute Beck's cognitive triad, and these are the 3. A negative, self-deprecating view of self. 2, a pessimistic view of the world. And 3, the belief that negative reinforcement or no validation for the self will continue in the future. So they just keep thinking those negative thoughts. They view the world in a negative way. General assessment. Assessment tools. I put a star next to it, so you know you need to know it. Look at this. The PHQ-9 is a short inventory that highlights predominant symptoms in depression. And so you're going to learn more about that PHQ-9, and it's a short survey, I should say, questionnaire that lets us know, like, whoa, this patient may have major depressive disorder. We need to look into this more closely. Or this patient may need a referral to mental health counseling for depression. Assessment of suicide potential. Look at this, guys. The most dangerous aspect of major depressive disorder is preoccupation with death. Death of who? Themselves. This world would be better off without me. I bring no value to this world. Because remember, the major depression is anger, hostility, resentment towards who? Themselves. Okay? They have suicidal ideations. Suicidal ideation, especially in those in which the patient has a plan and the means to carry out the plan, represents an emergency requiring immediate intervention. So let me tell you something. If you even suspect that that patient is having thoughts of harming themselves, the very first thing you do is ask them, are you having thoughts of harming yourself or killing yourself? You don't beat around the bush when it comes to suicide. And if they say, yes, I am having suicidal thoughts, well, what are those thoughts? Do you have a plan? So you ask them if they're having thoughts of killing themselves. And number 2, do you have a plan? And you listen to that plan, because that plan will tell you the lethality, how lethal their plan is. Okay, is this patient in immediate danger? Like we have to hospitalize them right now. We have to Baker Act them. We can't leave them alone. Or you know, it's still lethal, but it's not as lethal. So an example is if they tell you, well, my plan is to kill myself with a gun. They tell you the plan. The next thing you're going to ask them, do you have access to a gun? Right? If they have access, you know that plan's very lethal. But if they tell you that they're suicidal and you ask them if they have a plan and they say, yes, my plan is to jump off of Mount Everest, but we're in Florida, how lethal is that plan right now? So you're going to ask them, do they want to harm themselves or kill themselves? Do they have a plan? And do they have access to however that weapon or however they plan on harming themselves? That is the first 3 things you ask them in that order. Okay. Patients diagnosed with major depressive disorder should, look at that word, always, remember what I told you about these type of words when you're studying, when you see always, never, avoid, only, first, last, primarily, right? those type of words, I told you, when you see it, you better pay attention because those tend to be test questions. Look at what it says. Patients diagnosed with major depression disorder should always be evaluated for suicidal ideation. Why? Let's scroll back up. And look what it says right here. It says that the most dangerous aspect of major depressive disorder is preoccupation with death. What type of death? Suicide. So any patient that's diagnosed, excuse me, with major depressive disorder, they better be evaluated for suicidal ideation. Risk for suicide is increased when depression's accompanied by hopelessness. They don't even see themselves getting out of this. They see no hope. So what's the point of living? Substance use problems. So certain chemicals, right, can change your thinking, and that can cause you to make a rash decision. A recent loss or separation, especially of a very close loved one, that person just wants to be in heaven with their loved one. A history of past suicide attempts. They've tried this before. They're not joking. And let me tell you something, for the patients that have a history of past suicidal attempts, their risk is even higher because remember, they have anger, hopelessness, hostility towards self. I'm so dumb. I can't do anything right. I can't even kill myself right. So these patients are at high risk for suicide attempt, okay? And acute suicide ideations. You better know these. That looks like a beautiful select all that applies to me. If I were a nursing instructor, I would definitely make this select all that applies. Okay, so this is your PHQ-9. This is the screening for depression. Notice that I said screening and not diagnostic tool, because if this is positive for depression, it doesn't mean that the person has to be diagnosed with depression. It just means that that patient needs to be assessed further, and maybe some referrals need to be made by the nurse practitioner, the physician, the PA, whoever. Okay, so this is the PHQ-9. These are the questions that are asked. I'm not going to read them to you guys. You can take a look for yourself. Press pause if you need to, and you see what points are allocated on depending on how that patient answers these questions 1 through 9. And then here's the rating tool, the determination. So if the score is very low, the chances are that they have depression. The severity of depression, I should say, is none. 5 to 9, mild. 10 to 14, moderate. 15 to 19, moderately severe. And then 20 to 27, severe. Those chances are very, very high. So make sure that you guys know the PHQ-9, you know the screening tool, you know these questions. All right, let's take a look at this study care plan. I'm not reading all of this. I'm getting to the point. So we're talking about depression. Let's talk about short-term goals. Patient will remain safe while they're under your care. Who cares about anything else if that patient committed suicide? That patient committed suicide under your care. You did not understand the assignment. Okay, so our short-term goal is the patient will remain safe while in the hospital. What are we going to do to make sure that happens? We're going to be observing them every 15 minutes while they're suicidal. When I say observe them every 15 minutes, you, the RN, you may come in, observe them every 15 minutes, but you are going to have a person with them at all times. While that risk is acute, they're going to be a one-on-one. They're going to have a one-on-one sitter with them. Remove all dangerous objects from patient. Make sure that they don't have any medications on their person that they can overdose on. Make sure they don't have a gun in their purse. Make sure they don't have anything on them that they can actually commit suicide. Look at 2, patient expresses at least one reason to live. Can they come up with at least, because remember, hopelessness, when the patient has hopelessness, they have no reason to live at all. There's no hope. You want them to be able to express at least one reason to live. And this is apparent by the 2nd day of hospitalization. So that's our second goal. How are we going to do that? Spend regularly scheduled periods of time with the patient throughout the day. That is very important. Let me tell you why that's important. You just sitting there with that patient, let's say they don't want to talk, they refuse to talk. That is fine. If you schedule every single day, you're going to sit with that patient for 15 minutes, don't give up their 15 minutes to go care for another patient. You stay with them for 15 minutes, even if it's in silence. You sitting with them, even if it's in silence, that's still therapeutic communication. That's called what? Offering self. That is nonverbal therapeutic communication. You're letting that patient know that you have value. Even though you don't want to talk, I'm going to still sit here with you for that allotted time, just in case you change your mind, because you have value to me. And that is very important. Offering self, you need to know that. Encourage appropriate expression of angry feelings. I don't know why I didn't put a star next to it, because it deserves it. That's a good thing. When they express anger or they get offended, it's a good thing in depression. Why? Because let me tell you something. Before, when they felt hopeless, when they felt that they had no value, they didn't get upset about anything. What's the point? Life is meaningless. I have no value. Why would anybody care about me? But once they start showing anger, once they start showing that they're offended about something, that means that they're starting to see value in themselves. If the wife said that she was going to come visit and she didn't come visit, and he gets angry, that's good, because he's starting to see himself as valuable, as worth the visit. And how dare she not come visit when she said she would, because I'm worth that time. So that is actually a good thing. We want them to be able to express feelings of anger. That's number one. And number two, did I not tell you that depression is anger, resentment, hostility towards self? It's on the inside. So once they start expressing it, it's coming what? On the outside. So it stops being on the inside and it's coming on the outside where we want it to be. This is a famous test question, so I want to make sure that you guys understand this concept. Don't fall for it. It's not a bad thing. It's a good thing. Accept the patient's negativism. Now, take a look. Acceptance enhances feelings of self-worth. So when that patient says, oh, I'm unworthy, don't argue with them. Don't say, oh, don't say that, blah, blah, blah. Don't argue with them, because then when you argue with them, you're just solidifying the fact in their mind that their opinion means nothing. When they say, I'm worthless, you explore that thought. You can say something as simple as, you feel you're worthless? And then allow them to elaborate more. Allow them to express their feelings. So that's very important. Now, what you don't want to do, though, I want to make sure you guys understand that, is use silence. Silence is a great thing. It's offering self, but not when the patient's using negativism, not when they're putting themselves down. Because if they say, oh, I'm so dumb, nobody loves me, and you're quiet, you're just like, what are you saying to them? You're saying to them, yeah, you're right. You are dumb. Nobody loves you. So you don't stay quiet. You have to say something, but you don't argue with them. You help them explore that feeling. And it could be something as simple as you repeating what they just said so that they can elaborate more. Or you can say something like, tell me more about these feelings of being worthless that you have. Okay. Key assessment findings: a depressed mood and anhedonia are the key symptoms of depression. What did I tell you about key? That's one of our key words that I told you about, right? When you're studying and you see it, it's important to know. What is anhedonia? That means that loss of pleasure, things that the patient used to find pleasure in, they don't find pleasure in it anymore. So depressed mood and loss of pleasure in things that they used to find pleasure, those are key symptoms of depression. What did I tell you when you're studying and you're seeing the same information repeating itself? Because the author gave us this information here in the text, but didn't we see the same thing a couple pages right here? Yeah. Whenever you guys are reading or you're studying and you're seeing the author telling you the same thing, except in a different way, it's important to know. Most likely you're going to see it on a test somewhere, okay? Anxiety is a common symptom of depression. Feelings of worthlessness, hopelessness, guilt, anger, helplessness are common. And it's pointed to who? Themselves. All right, let's talk about affect. Affect, this is the outward representation of a person's internal state of being and is an objective finding based on the nurse's assessment. So what are they saying? For example, if I'm happy, right? My affect will be this. I'm smiling, you can see that I'm happy. So the reason it's objective, remember, something that's objective means it's measurable. It's something that you can see. It's not like pain where you can't see the pain, but the happiness, the laughing, the giggling, that's something you can see, can't you? So affect is the outward representation. Or if I'm upset, I'm crying, or I'm pouting, or I have a scowl on my face. Affect is the outward representation of how that patient's feeling internally. Feelings of hopelessness and despair are readily reflected in the person's affect. You can see it in their face. You can see it in their body language. They're not sitting up straight. Their posture is straight, as if they have confidence. They're stooped, head down, refusing to make eye contact, stoop shoulders. For example, the patient may not make eye contact, may speak in a monotone voice, may show little or no facial expression, that's a flat affect, may make only yes or no responses, frequent sighing is common. That looks like a beautiful select all that applies to me. All right, thought process. What would the thought processes of a depressed person look like? Judgment, or the ability to make reasonable decisions, is poor. That person who's depressed, something as simple of asking them which shirt they want to wear, even just walking them to the closet saying, pick out a shirt, it's hard for them to do that because they're so severely depressed. Their thought process has slowed down that they can't even make a decision. So those type of patients who are severely depressed, you cannot give them choices to make where they have a lot of things to choose from. Choose 2 shirts and say, would you like the red one or the white one? Don't walk into the closet and say, what do you want to wear? Okay. Where was I? This poor judgment leads to indecisiveness. They can't make up their minds, which makes it difficult to make simple decisions such as what to wear or what to eat. So these type of patients, you're not going to say, oh, what do you want to eat for lunch? You ask them, would you like the mashed potatoes or would you like the string beans? Keep the choices limited because they have a hard time with making decisions. Mood. All right, guys, this is like the second or third time I'm seeing that word, anhedonia, without pleasure, the inability to feel happiness. Things that used to bring them happiness and joy no longer does so. Feelings. You guys start to see a pattern here. You start to see the same information repeating over and over and over again. That's why it's going to be a test question. Feelings of worthlessness. Guilt is nearly a universal what's this word? How do I pronounce it? Accompaniment. It comes with depression. I'm not going to try to pronounce that word. I know what it means. I just can't pronounce it. So guilt usually comes hand in hand with depression. But remember that guilt is what? It's internalized. Cognitive changes, the way that they think, the way that they process their thoughts. Helplessness is demonstrated by a person's inability to solve problems in response to common concerns. They cannot make decisions. Even though most depressive episodes are time limited, people experiencing them believe things will never change. They don't see a light at the end of that tunnel. Feelings of utter hopelessness can lead people to view suicide as a way out of the constant mental pain. They don't see a light at the end of that tunnel. Hopelessness includes the following attributes. Here they go. Negative expectations for the future. They don't see anything good happening, so they have nothing to live for. Loss of control over future outcomes. You know what? Something bad's going to happen and I have no control over it. I have no control to make things better. passive acceptance of futility of planning to achieve goals. So your job as a nurse, you're trying to help that patient come up with goals for themselves and achieve them. But they don't want to be active in this planning phase. They just want to just go along with the program. If you say I got to do it, then I guess I'll do it, but I'm not taking an active role. Emotional negativism expressed in despair. It's the end of the world. I'm hopeless. Nothing good's going to happen. Despondency. I'm not being an active participant. The person's despondency, they're not participating. You ask them a question, you're trying to engage them in conversation. They're giving yes or no, 1 or 2 word answers. They're not trying to participate in any type of activity or conversation. Depression. Anger and irritability are natural outcomes of profound feelings of helplessness. And remember that anger and irritability and helplessness is turned towards themselves. Physical behavior. Most people with depression experience anergia, which refers to abnormal lack of energy. That patient doesn't even want to get out of bed. They want the curtains drawn. They want the blankets over their head. They're so depressed, they don't even want to move. They don't even want to eat. The act of eating is exerting too much energy for them. Anergia may result in psychomotor retardation, in which movements are extremely slow. Facial expressions are decreased. They have a flat affect. And gaze is fixed. Conversely, some patients may experience psychomotor agitation. We may see the opposite, manifested by pacing, nail biting, finger tapping, or engaging in some other tension relieving anxiety. Let's stop right here. What does this tell us? Even though for the most part, most patients will, they don't even want to move, we may see the opposite where they're agitated, they're moving. But that has to do with what? The anxiety that often comes with depression. That's why it says tension relieving activity. That's anxiety that they're trying to relieve. Subjectively, patients commonly feel fidgety and unable to relax. Vegetative signs of depression. This refers to alteration in those activities necessary to support physical life and growth, such as eating, sleeping, elimination, and sex, where we'll see that they are physically unable to eat. Some patients are so physically depressed, you have to actually feed them. They won't get up to eat or even go to the restroom. Appetite loss is common. Other patients find that they eat more often and complain of weight gain. Don't let something bad happen to me. I'm finding the closest tub of mint chocolate ice cream. Change in sleep pattern is a cardinal sign of depression. Cardinal sign, that's another word. Okay. Cardinal is another word for hallmark, which is one of the words that I taught you to watch out for when you're studying as well. Okay. That is, you see a change in sleep pattern, that is a hallmark sign of depression. All of a sudden, either they're sleeping all day or they can't sleep at all. They often experience insomnia. They wake frequently, waking at a total, they wake frequently, a total reduction of sleep, especially deep stage sleep. So even when they do fall asleep, the sleep is very light. Any little thing will wake them up. It's not really that REM sleep. Waking at 3 or 4 a.m. and then staying awake is common, as is sleeping for short periods only. Changes in bowel habits are common. Constipation is seen most frequently in patients with psychomotor retardation. And it makes sense because we know when we want to prevent a patient from being constipated, we have them drink lots of fluid, eat lots of fiber, and what? Move. But these patients that have psychomotor retardation, they're not moving. So everything slows down, including their GI tract, including the peristalsis. So we tend to see them constipated. Sexual interest declines. They have a loss of libido during depression. Some men experience impotence and declining interest in sex. Grooming, dressing, and personal hygiene may be markedly neglected. Why? Because if they see no point in living, why would they want themselves to be clean? Why would they groom themselves? All right, guys, we're going to stop here. Next on part 2. Actually, no, let me go over assessment guidelines. And then part 2, I'll start on implementations. So assessment guidelines for depression. Number 1, before you do anything else, always evaluate, always, that's a key word, always evaluate patients' risk of harm to self or others. Overt hostility is highly correlated with suicide. The very first thing you better do is assess their risk for suicide. Are you having suicidal thoughts? Do you have a plan? And do you have access or means to fulfill that plan? Those 3 in that order. 2, a thorough medical and neurological examination helps determine if the depression is primary or secondary to another disorder. Because we may think the patient has depression and come to find out they had hypothyroidism. So we need to rule out other potential causes of what's going on with that patient. And here's some other causes we have to evaluate. If they're psychotic, are they even in touch with reality? Are they under the influence of drugs or alcohol? Medical condition, again, such as hypothyroidism. Do they have a comorbid psychiatric syndrome such as borderline personality disorder, anxiety disorder, etc.? 3, you want to assess the patient's history of depression and suicidality. Remember, if they have previous attempts, that increases their risk for attempting suicide again. And assess their support system, family, significant others, etc., and get them involved in the patient's care and the plan of action for that patient. All right, guys, so this was part 1, depression. Part 2, I'm going to get started on implementation. What are your responsibilities as the nurse going to be for that patient that's depressed? I hope you guys found this video to be helpful. Let me know in the comments what you'd like to see me cover or cover more in depth. Don't forget, guys, on Sundays at 1 p.m. Eastern Standard Time, I have questions that are released on this YouTube channel. You guys can find me on TikTok, Instagram, Facebook, where I go over different questions than you guys find Sunday, 1 p.m. Eastern Standard Time. If you haven't done so already, please, guys, don't forget to like this video, subscribe to this channel, help my channel grow, guys, because the more that my channel grows and I get support for this channel, that allows me to have more time to do things like this for you. So please don't forget to share my content. If you're in the nursing program and you have classmates that are struggling, or maybe show my content to your nursing instructor, help my channel grow. Don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com, and you guys will see me on the next video.